one of the major presentations at ASCO is a presentation that went into plenary session, Keynote 177, that assessed the role of pembrolizumab as a PD-1 inhibitor in first line versus standard chemotherapy, whatever your preferred chemotherapy plus biologic, plus minus biologic is. And this study was looking at showing an improvement with progression-free survival with pembrolizumab. This was in an MSI-high patient population with metastatic colorectal cancer. The study was positive, and essentially the hazard ratio was 0.60, but at the median PFS was 16.5 months versus 8.2 months with the pembrolizumab. So a little bit more, touch bit more than double the median progression-free survival with pembrolizumab. And that's essentially amazing. I mean, given the fact that about 1/3 of those patients will never need chemotherapy. So first-line pembrolizumab, just changing completely the way we see this. In all frankness, in my clinic, I've favored using pembrolizumab over chemotherapy in the first line. So that study actually consolidates that. The other interesting aspect is the response rate was close to 50% with pembrolizumab in the first line versus 33%. And the durability of response was much higher with pembrolizumab. In fact, it was not reached. And less toxicity. So less toxicity, improved PFS, improved duration of response, improved response rate. We haven't seen the overall survival data yet. That's still going on. And so overall, our first line standard for microsatellite instability, so MSI high patients, is pembrolizumab, and chemotherapy is displaced. How about the group with microsatellite stable? There's not much activity with single agent pembrolizumab or nivolumab, but what we're seeing is essentially a number of strategies moving forward. One of those strategies is with regorafenib and nivolumab. Recent Journal of Clinical Oncology paper published, phase 1b in Asian population, showed with a combination of 80 milligram of regorafenib, so lower dose, with nivolumab, a response rate of 36% was seen in colorectal cancer with a combination of the two, and these are refractory patients, and a median PFS of 7.9 months. We're also seeing very interesting outcomes in gastric cancer. The only challenge was the toxicity. There were some significant rashes with this combination. So ongoing studies, including phase 3, is looking at the role of this combination in microsatellite stable metastatic colorectal cancer. So we will have more data with the combination of these two in microsatellite stable disease.